Hello, my name's Fiona and I'm the clinical nurse specialist for outpatient and antimicrobial therapy at Frimley Park Hospital. I'm looking forward to talking to you today a bit about what outpatient antimicrobial therapy is. So what is OPAT? Well, some patients need ongoing IV antimicrobial therapy, but they're too well to be in hospital. They've got a long haul perhaps, and they're desperate to get home. And if they're stable, that's where people should be. So you have an outpatient antimicrobial therapy team. On the Frimley site, it's me, Fiona, in the photo, and on the Wexham site, it's Hilary Hodgson. But it's different over there. Both sites have a slightly different OPAT service, and there's a number of reasons behind that. Each service has a slightly different referral pathway. So at Wexham, they specialise in caring for patients who need more than 2 weeks of IV therapy. These patients will be taken on into the multidisciplinary team, where Hilary is the clinical nurse specialist, a microbiologist, and any nurses involved in the patient's care review the patients on a virtual ward round every week, review the plan of care that's in place, and feedback to any other clinicians and the patient about whether they're ready to change their therapy or not. Patients over there are taken from Berkshire, and the CCG commissions an elastomeric pump service, which is an elastomeric pump is a device that's pre-filled. You attach it to the person's vascular access device, and it delivers all the medication as if by magic. Now at Frimley, it's slightly different. We use an ambulatory care pathway. We're not specifically in ambulatory care, however. So any directorate can refer in, and patients can have just a couple of days antibiotics that's needed, but sometimes they have months and months of antibiotics that's needed. But one thing is common is that when they're off the IV antibiotics, they're discharged from the OPAT team. So we take slightly different patients from slightly different sets of circumstances, slightly different geography, but the best thing is, if you're not sure, talk to one of the OPAT nurses. So who can have OPAT? So as I said, patients from all directorates can be referred for outpatient IV therapy, and obviously you're working in surgery. Most have been inpatients that come onto the caseload, and they're continuing their IV therapy after an episode of an acute illness. Some, though, come into OPAT from the outpatient departments. They may never have been in a hospital bed during this episode of their care. They're referred in directly from hospital consultants and start IV therapy down in G7. This tends to only happen on the Frimley site. So remember, all patients that are being discharged home from hospital on IV antibiotics should be known to the OPAT service. That's every single person that you send home who needs IV therapy should be seen by a clinical nurse specialist for outpatient antimicrobial therapy. But we know that doesn't always happen. In an ideal world, you should let the OPAT team know 48 hours before an expected date of discharge is in place. Quite often, some of the surgical patients have needed quite a bit of IV therapy, and you know at least perhaps a couple of days before you're planning to get them home what you're thinking might happen. And at this stage, the surgeons are doing lots of toing and froing with microbiology. Just let us know. We'd rather know someone was on the radar and we could come and see, even if they switch to oral antibiotics before they go home. It's good for us to meet them before we have to make that step and discharge them in a bit of a rush. So OPAT patients must all be over the age of 18. It's written in our policy. They should also have a consultant who remains entirely accountable for their clinical care whilst they're on IV therapy, even when they're receiving therapy at home. So really it's like they're an inpatient as an outpatient. They just haven't got a bed in on the hospital site, but they are still classed as an inpatient. They're still receiving care that would normally be delivered in a hospital. So it's quite important that they understand that actually there is a bit of a deal here, that if things aren't right, you're going to come straight back into a hospital bed. They also need to have a clear treatment plan in place. So it's no good sort of saying, oh yeah, a couple of weeks of IVs and then we'll see what happens. They actually need a firm plan in their discharge letter. When are we going to see them in clinic? Is it going to be every couple of weeks? How often are we going to do the bloods? Who's going to look at them? How do we decide when they're ready to change onto oral therapy? Those things need to be in place before that patient leaves the building. They should also be known to a microbiologist, and these are particularly for the surgical patients. It's a bit easier in people on a cellulitis pathway, for example. There's a clear and defined set of circumstances that we follow. We know what's going to happen and we know when the review's going to be there. However, some of the surgical patients have very complicated IV therapy needs, and they must have seen a microbiologist or have a microbiology consultation prior to any discharge that takes place. This is particularly important as many OPAT patients need to have the frequency of their IV antibiotics reduced to maybe once or twice a day. And it's only the advice of microbiologists that can really put this into place, which medication is going to be the best longer term. Also, patients must have weekly bloods that are reviewed by the nurse specialist usually. It's really important because the longer term, long-acting antibiotics do really affect people's blood chemistry. They can really mess up your LFTs. Of course, we want to see your CRP rising, but they can also make you neutropenic and eosinophilic. They can give you diarrhoea. They can do all sorts of things to you. And it's important that we maintain our antimicrobial guardianship by getting people off IV therapy and onto orals as quickly as possible. So the patient must agree to have weekly bloods in the community or even in the hospital and come to clinic each week to make sure they're reviewed. So how can we make it work? Things don't always work. Patients don't fit into boxes. So sometimes it is a bit of a challenge. There are several things to think about when you're assessing a patient to see whether actually outpatient antimicrobial therapy is going to work for them. The most important thing before considering these things is actually, are they stable enough to even think about going home? Some conditions can deteriorate quite rapidly, and they're the ones that you need to keep in hospital. We must have a medical team, surgical team, who are happy that the patient is stable enough in their condition that they can ambulate. And then we need to think about the other factors that come into making things a success. So the first factors can be grouped together into socio-demographic status of the patient. So things that get in the way of things being a success in terms of therapy are things like living alone. Living alone leaves people a bit at risk. What happens if they become unwell? Are they going to initiate getting help? What happens if their vascular access device falls out in the middle of the night? Who are they going to go to? And they need to be reasonably stable in terms of, do they care for anybody else? If they're caring for somebody else, they're not going to be as good at caring for themselves. And actually, they're still ill. They're still on treatment that you would normally give in a hospital. So they're not going to be back to their normal selves. They get tired. They feel exhausted. And a lot of the time they think, oh yeah, I'm going home from hospital and things are going to be great. But as I say to them, you are officially on sofa duty. You've got a condition that we'd normally treat in hospital, and things aren't going to change overnight. How's their mobility doing? Are they able to get out and about? Living in a care home, that really causes some difficulties, as not all our colleagues who are nurses in a care home environment can administer IV therapy and maintain their competence. And we had a situation like this a couple of weeks ago. And we looked at whether we could train our colleagues out there to give the IV therapy. But actually, it was okay for that person to try an oral regime. So sometimes we need to think a little bit outside the box. Has the person got stability in their housing? They can't really have IV therapy if they're homeless. It just doesn't work. They need that stability in life. Sometimes young people can be a bit reluctant to engage in a treatment plan or maintain dosing schedules or have bloods on time. They're keen to get back to work if they're working. it's difficult for them to maintain a vascular access device when you want to go down the gym and do your kettlebells, or you want to swim. And these are the deals you have to make with people to maintain their safety. They also find it a bit of a bind. They want to go out drinking with their mates. So it's not every young person is like this, but there's sort of things that you have to think about. And the other thing to think about is someone is going home and they're needing support from our other nursing colleagues in the community. What's their home like? Do they have a phone? Have they got running water, electricity? Have they got the scariest dog? And those are things we need to make sure that we've assessed to make sure the things are safe for our colleagues to go into. So the next group of things to think about are the way that people actually think and process the whole concept of outpatient antimicrobial therapy. So things like cognitive impairments, mental health problems can really get in the way, and I would think very seriously before somebody within those brackets it would be suitable for outpatient antimicrobial therapy. That's not to say that they'd be discounted entirely, but you'd have to take into consideration all the other factors in making an assessment for outpatient antimicrobial therapy. There's lots of evidence that the level of education has quite a bit to do with how successful outpatient antimicrobial therapy can be. And actually, the high level of academic attainment by an individual has a direct link to the success that they meet in their treatment. They seem to be able to take on board things and initiate support and engage more so than a person of a slightly lower academic attainment. It's really important that we look at how well our patients understand written English as a language. Most of our inserts for our medication and instructions are written in English. And that's not necessarily a great thing. We do need to, as a service, work a bit more carefully on how we share information with our patients who don't speak or read English as their first language. Another thing that's discussed in the literature is low health literacy. So people who don't really see the benefit of any of this treatment. Why is it a bother? I just want to get home from hospital. I don't really care what you say. I'm going to just say yes to everything. They don't perhaps understand what a commitment having outpatient IV therapy is all about and how serious things can be. It's not just going home. So it's really important that people appear committed to the therapy plan, you work with them as a team, and that they're engaged and understand about what you're trying to achieve. So thinking about ability and comorbidity, we have to try and consider the burden of other diseases that the person may have. It's very difficult to administer your own IV therapy, drawing up everything that nurses like us do at the drop of a hat. But what if you had arthritis in your hands? How would it feel trying to pull back on a large syringe of fluid? What would happen if the syringe fell out? How do you get the needles on and off? So really quite practical issues that perhaps we don't think about thoroughly. What happens to our patients when they're tired? They're fatigued. They might have breathlessness. We need to think about how and where they're going to be when they prepare their IV therapy and how they're going to manage that within their own environment. And are they going to be able to run to a set routine? And as I said, younger patients sometimes find this a bit more of a struggle, but timeliness of their IV therapy is really important. Things shouldn't be given too late. So what about initiative and responsibility? So is the person able to report an issue to a caregiver? What happens if there's a problem with their vascular access device? It feels red or hot or hard or painful. Can they initiate getting support with that? What if they're getting fluttery palpitations? That needs to be fed back to one of the OPAT team so we can address anything that's going on. So they need to be able to escalate things if things don't feel right. And they need to have a good relationship with the OPAT team so they feel comfortable in doing that. Stability in socioeconomic status comes in with if someone can engage in coming back to clinic and coming back to pharmacy to collect their medications. If you're financially struggling, it's extraordinarily expensive to catch a taxi to Frimley to get your drugs. And if you don't need to go to clinic, why go to clinic? And that's become even more important now with the coronavirus problems that we've had. Luckily, we do a lot of our clinic work virtually, and we get a lot of our patients to have their weekly testing as locally as possible. They do also need to have access to a phone. Sometimes they need access to a smartphone if we're teaching them how to infuse themselves. And we need to think about things like, have they got childcare responsibilities? Where are they going to put that enormous sharps bin that we're going to give them to keep them out of the way of the kids? And how are we going to get to dispose stuff? Are they going to be able to eat well through all of this? So there's lots of things there to think of. And the last set of circumstances to consider are the behaviours and the lifestyle of the person that may get in the way of having a good course of treatment. The ones that we always think of first are IV drug users. And at Frimley, we don't take IV drug users onto the OPAT caseload. That's been questioned a lot, actually, when I've discussed it outside the trust. We don't, as a rule, in a demographic around the Frimley site, we don't have an enormous problem with IV drug use. But the IV drug users that we do have do get infections. And they've also got terrible vascular access. We have to weigh up the pros and cons of whether there's a problem that we can treat or not. Now, I'd say the policy says never have anyone who's using IV drugs or has used IV drugs. But recently we've taken the risk, a calculated risk with 2 individuals that had both used IV drugs in the past and actually have done really, really well on outpatient antimicrobial therapy. And we put a plan of care in place that they came into the hospital every day until we were comfortable that they were responsible enough in their thinking and responsible in their actions that they were going to stick to the deal and get through their therapy successfully. It's also worth thinking about people who have other addictive behaviours like alcoholism. That often impacts on people's initiative, responsibility, the way they think and process and get help. So that's not always helpful. We've mentioned homelessness before. We don't use OPAT in the incarcerated population. But the most important thing is that people are willing and cooperative and engaged. But also, they have to have a regime that's easy to deliver outside a hospital. It's really hard for people to commit to outpatient antimicrobial therapy. We want to give the person the best drug for their infection and at the lowest number of administrations per day that we can. And you'll realise that from your practice that we often give drugs called ticaplanin or ceftriaxone, both of which can be given once a day. Ertapenem, which we do rarely give, that's also once a day. And then after that, we tend to look at drugs that might be given twice a day. To give more than twice a day, we have to teach the individual how to do it. And that's really quite a commitment for them. And we don't do it very often, more than twice a day. One of the most important things is the patient has a suitable vascular access device. So you'll see our patients going home, or you'll see me come to the ward. Has the person got a PIC? So a peripherally inserted central catheter. They work really, really well for OPAT, but become a bit more difficult when you're trying to teach someone to self-administer. They need to have an extension put on. So the PIC will be in their upper arm, and that means they can't use both their hands to administer. So we put an extension line on, and that means that they can use both hands to attach to the PIC and give their drugs. Other patients we might fit with a Groschong midline. They're the little blue ones that come out of the antecubital fossa and are stuck down to the patient's inner arm on the lower arm. They work really well and they can stay there for 6 weeks. And people tend to do really quite well with them. We do use some other midlines that are not so long lasting. And they are okay for OPAT, but they can sometimes fail a bit more easily than a Groschong or a PIC. So it might be that when I come along and see your patients, I might say, I think we need to change this over to a different type of device. And I'd ask one of the vascular access team to come and do that with the patient. It might be a bit confusing for them to understand why they've got one device that already works, so that this nurse comes along and asks me to have another device that works. But it's a question of going through which one works best in the community, which one's the most easy to maintain. Really important they have access to a phone. They need to be able to initiate getting help if it goes wrong. So OPAT shouldn't be an IVDU, be that past or present. They shouldn't have impaired mental capacity. Ideally, they don't live alone, and that's in case something goes wrong and they can't initiate getting help themselves. And they don't tend to live in nursing homes, although, as I discussed, we can start looking at those things going forwards now, where we've got different services in place in the community. So what can go wrong? So the first thing is signs of the overall infection that the person's being treated for deteriorates. Knees that have been infected and washed out start to get red and hot. People have rigors. The CRP starts rising. We have to do something about it. And that's when we'd look at stopping OPAT and perhaps admitting the patient. Maybe they start having some drug-related side effects. That might be the liver function going completely awry. That might be having intractable diarrhoea. It could be anything really related to the drugs, rashes, all sorts of things. We need to address that, change the therapy if we can, or readmit them if we have to. So the VAD becomes compromised. That's the vascular access device. So it might migrate, as in it gets pulled out a bit. How far can it get pulled out before it has to be replaced? Is it infected? How do we know the person can do their own VIP scoring, for example? And we need to teach them all of those things that a nurse would do each day if they're self-administering. So that's where we'd get in touch with the vascular access side of the team, and the patient may need to come back in and have things looked at. So a MARSI is a medical adhesive-related skin injury. So I don't know whether you've seen when you're doing your care of your vascular access devices, sometimes the film dressings can pull a bit of skin off or they get some blistering. This can be problems related to the glue in the dressings, but most commonly it's where the chlorhexidine cleaner isn't allowed to dry long enough under the new dressing. It just sits like a puddle underneath, and people get really irritated skin. If their skin becomes compromised, it means the vascular access device becomes compromised, and if the vascular access device becomes compromised, then the person may not be able to continue on IV therapy, and we might need to think of something else. A classic one, the patient changes their mind. They don't want these people coming into their house. It's driving them nuts. Why can't I do it myself? I've had enough of this. I've had enough of not being able to have a beer with my mates. Whatever it is, they've changed their mind, and we need to try and think of another solution. They might be unable or unwilling to attend a clinic. Every patient's told that they may need to attend clinic for the OPAT service each week, and quite often they don't, because we can do a lot of it remotely. But if they change their mind, then we have to think again about how we continue, if we continue. They may be unable or unwilling to collect their medication. Again, we talked about socioeconomic status earlier, and that's usually the one that gets in the way. And they may have underestimated how much of an impact this treatment will have on their lives. They feel tired, they're fed up, they've been in hospital for ages, they may need to go back to work, they've got to commit to giving this medication to themselves each day. And if they're on a very long treatment of 3 months, it can be a real hard slog. So how do we manage the risk of working out whether this treatment's going to be a success? So the key thing is investing in the assessment of the patient. You must be thorough. Think about all those things we've just gone through. Where does the person live? Who do they live with? How are they going to get their medication? What kind of gadget have they got in their arm? How are you going to strike up a deal with this person? And that really comes from the OPAT side of the team. I need to be visible and contactable. I'm usually quite friendly and will have a bit of a chat with people. But we need to form that relationship and share the ownership of the person's care. Otherwise, it doesn't work. I must provide good written information, and you might have seen the PIC passports or the midline passports with lots of contact numbers in. Must go out with the patient. We must have clear parameters of what's going to happen next. What day am I going to have my blood taken? What day are you going to look at them, Fiona? When will you ring me and let me know that things are going okay? Clear treatment plan. They know when they're coming back to clinic, and they know when they're going to get reviewed. So how do we give this OPAT stuff? So there are several routes. First one is they come to hospital every single day. The second one is our district nurse colleagues may administer the medication. We may train some carers to administer the medication, and we may train the individual to administer the medication. So option 1, coming to hospital every day. So at Wexham, the patient would come to Eden Day Ward, or at Frimley, they would come to the G7 intravenous vascular access department. Sometimes they maybe need seen in other departments at the weekends because each unit isn't always open. And that's where we may rely on our colleagues in medicine or surgical assessment unit to deliver the care at the weekend. So it's really important that the notes, especially the drug chart, follows the patient around. Otherwise, it gets really confusing. So district nurses, that can be really interesting to set up. Certainly on the Frimley site, we cover about 7 or 8 different hubs of district nurses. And we've discharged patients back as far as down into Sussex, all the way up to Newbury, and over in Fleet, Nodium, normal places like Farnborough, all over the place. And each different area does a different thing with a different team, with slightly different levels of service. Some of them might take infusions, some of them might not. Some of them might go once a day, some of them might go twice, some of them may say they're not even going to be able to do it at all. And that's where the OPAT nurse might come in really, really handy, because she might just take over setting it up for you and negotiating with the community teams. Most important thing you can do is get the community drug chart. And again, I can't stress enough, get hold of one of the OPAT service, because they've got them all to hand and don't need to find one in the bottom of the drawer which has the wrong logo and get sent out and then get sent back in, and you end up trying to undo everything. You might be able to see on the bottom of this slide, these things are little plastic bottles, and those are elastomeric devices. The medication gets put into the cylinder and it blows up like a balloon, and it works like a pump, but it just releases the medication over a 24-hour period. Now, they have those at Wexham. They're really, really lucky. Unfortunately, we don't have them at Frimley yet, but I'm working on it. The other thing we're looking at as a trust is coordinating a single community drug chart that everybody will be able to recognise and every community team will be able to accept. So no more rummaging in drawers, hopefully. So carer and self-administration. Anyone who meets the OPAT criteria could be assessed for self-administration, and that doesn't have to be by one of the OPAT nurses. Any registered nurse who's competent in IV drug administration can assess whether a patient or their carer are competent to self-administer. So just think through the other things that we talked about. What are the good bits? Is somebody able to initiate getting help? Are they dexterous? And are they, or is that not going to work? There's a capability assessment that must be done and filed in the patient's notes. And you also need to share that with pharmacy. So here's the form. It's available on the intranet. There are lots of things to go through on the form, and everything needs to be achieved before the assessor, so the registered nurse, and the patient or their carer sign it as a contract that they're going to administer IV therapy at home. Now, the tricky bits are if the drug is an infusion. It's a lot easier to teach patients and carers to give bolus doses. It's quite hard to teach them how to make up an infusion and drip it in at the right rate. That's only an issue on the Frimley site. The Wexham team have got the elastomeric devices where you just teach them to hook on to the patient's vascular access device, and the gadget will do the rest. But at Frimley, we might need to teach an infusion. We have to have a think about what size syringe do you need for boluses. And again, that comes back to the mobility and dexterity of the person who's going to be giving the drug. Yes, are they dexterous enough? Can they use both hands? Like we said about the PIC line, needing to be able to use both hands. And will they call if they need help? So if you think you're happy with that, refer to the OPAT team. Hopefully you might have referred before. There is a form, you'll find that on the internet, but you can bleep, you can phone, you can even email. Any of those routes, and one of us will be able to contact you back and work out a plan. So these are some of the frequently seen conditions from the Surgical Directorate. We've had some infected vascular grafts. We have a few orthopaedic metalwork problems. We get a few discitises, and we've had some amazing sinusitis to deal with, ear problems, all sorts of things. So I was going to tell you a few case studies. So here's one chap, he's 72 years old, and he had some neck pain and came in, and he was diagnosed with discitis. He'd had really extensive orthopaedic surgery about 20 years before after a really nasty road traffic accident. He was already fitted with a PIC, and he needed 6 weeks of ticaplanin at 1.2 grams, which is infused over 60 minutes. And he lived in Alton, not exactly on the doorstep of Frimley Park. But he was motivated, he was very cognitively able, and really keen to give it a go. So we started discharge planning for the following week because he was still rehabilitating on the ward. So how did it go? So the next week he came every single day, 5 consecutive days to G7 to be taught in stages how to make up an infusion. His wife was going to do the self-administration. I showed them both how to do it, and he felt she would be better at doing it than him. So what we did was, as we don't have elastomerics, we used some smart apps you can get one on Android and one on Apple that do drip rate calculations. And they're actually designed for healthcare professionals, but they're pretty handy stuff. And as we were rolling the drip, so we do all the infusions by gravity, and the roller that you use with your thumb to regulate the drip rate, there's also on the smartphone, you can just tap as the drip drips, and it will tell you how quick the infusion's going to go. So it's important then that I worked out how many drips per minute the person needs to have, and that they knew how quickly or slowly they needed to give it. And all those instructions were written out stage by stage. So the deal was he would come back to OPAT clinic once a week, which he did, and at the end of the 6 weeks, he finished his ticaplanin and he was discharged. But a whole year later, he had a completely spontaneous swelling of his right hip, and he had a total hip replacement there in the past, sometime after the RTA. His prosthesis was found to be infected, so it was removed and replaced, but he needed 6 more weeks of ertapenem. Now, he'd done it all before. Ertapenem was only given over 30 minutes. This was a walk in the park for him. So we knew he was going to be all right. Couple of goes coming in each day, and he was away. And he did a really tremendous job at looking after himself and his PIC. They rang when they needed me. It worked a treat. So he was discharged. Now, it's not always as easy as that. This chap was 45 years old, and he had endocarditis. He'd come back from Harefields after a valve replacement that they'd found a vegetation on. His wife, though, was a clinician, and so was he. He had a PIC. It had already come from Harefield, so it looked slightly different to ours, but we kind of worked our way through that. And he was prescribed ceftriaxone 2 grams for 6 weeks. So he was just desperate to get out of there. He wasn't a clinician involved in IV administration, but his wife was working in a profession where IV drugs were given. She'd not done it for a long time, though. So we did a bit of training with him, and we did a bit of training with her, and she was not quite competent, but he needed to go home. So we handed over to the district nurses in that area to visit each day and give the medication and do the assessment at home, which carried on. And within a few days, the district nurses were able to hand over to the patient himself to carry on giving the administration. So he had virtual reviews by phone, Worked a treat. End of the 6 weeks, had his follow-up. No more treatment required. Worked really, really well. Now, this was a bit more tricky. So this chap was 84, and I start to worry about people when they're reaching an advanced stage. So he's older. He also had dementia, and he had an infected vascular graft. And found in it was Pseudomonas, and he'd also had MRSA, ESBL, and E. coli. So lots and lots of infective history. And when I saw him, what I was worried about the most was he had a PIC in, and he lived with his wife, who was a carer at a local residential home, and she worked nights still. So there'd been a bit of an age gap. So he was going to be on his own all night. And my biggest fear was that the PIC would become displaced. So that was my biggest worry. So I said I didn't want him to go home to start with. So we took he got sent home. One of the wards sent him anyway, and he was on ertapenem, and the district nurses went each day. But he couldn't come back to clinic, and his bloods would go over to Wexham, and it was really hard at that time to get them monitored and share the results. It didn't work well, although it was a success in a way, because the district nurses took over. They managed the PIC line migration when it did happen, and no harm came to him. So that was really positive, but it just was awkward and it didn't feel good. But he did succeed in his treatment, and his infection was treated effectively. So things to remember. Refer all your IV discharges to the OPAT team, and try and refer as early as possible, because you can see now how complicated assessment can be, and how it's much more helpful for you to get support early on with all the right bits of paper and things like that. Try and think of the bigger picture for the person. It's not as easy as banging someone out the door with a PIC in their arm. Try and get those TTOs to pharmacy at least 1 day in advance. It takes our pharmacy department at least 4 hours for them to process. And if they're not down by 2:30 in the afternoon, you can forget it for that day. So here's us, the outpatient antimicrobial therapy team. My name's Fiona. You can bleep me on 5935 on the Frimley site, or I'm very happy to take your call on 07467 353 691, and Hilary can be caught on 01753 633 000. Thanks for listening.